Good afternoon, everyone, and welcome to the Illinois Academy of Family Physicians webinar on adult immunization update, new recommendations, and overcoming barriers and hesitancy. Our presenters today are Dr. Corinne Kohler and Dr. Safia McNeese. Just a couple of housekeeping things. All attendees are in listen-only mode. If you have any questions, please put that in the chat feature, and those will be read at the end of the presentation. This presentation is being recorded and will be available online, so all discussions, questions, and answers will be part of that recording. The Illinois Academy of Family Physicians is accredited by the Accreditation Council for Continuing Medical Education, or ACCME, to provide medical education for physicians. This webinar and the enduring material online is available for AMA PRA Category 1 credit and also AAFP prescribed credit. At time of recording, the prescribed credit is still pending. We will let you know when that pending or that application has been approved. For our webinar attendees, a link to the post-test evaluation and the credit claim will be in the chat box at the end of the presentation. That is how you will receive your credit. That link will also be emailed to you along with a copy of the presentation after we are done. If you are listening to us online as an enduring material, a link to that post-test evaluation and credit claim is found under the video description. If you click on more, as you can see on the screen here, it'll open up full screen and you'll see this link. That link will either be at the bottom of your video or to the side. Fill that out and you will receive CME credit and certificate. Here's our faculty disclosure information. Neither our presenters nor myself nor our CME reviewer or scientific writer have any relevant relationships to disclose. And our funding for today was made possible by funds received from the Office of Disease Control through the Illinois Department of Public Health. And with that, I'm going to turn it over to Dr. Kohler.
Good day, this is Dr. Kohler. As I'm trying to get my screen share up, I am going to knock this down. Okay, hopefully you can see that. Our learning objectives are as on the screen. We're going to go through the CDC guidelines, talk about eye care, talk about barriers to vaccination and tactics and communication strategies. The agenda, first of all, we're going to go through the immunization updates, specific vaccines, eye care, the vaccine hesitancy and barriers strategies, and then we'll make sure you have additional resources. And again, if you have questions, please put them in the chat. If we don't have time to answer them, we will certainly be willing to answer them online. Talking about the immunization updates, there's a lot of information here to unpack. My goal today is to make sure you have the resources that you need going forward. Whether you are a clinic that currently vaccinates adults or just need the information, we're going to talk about the different immunization updates. So, vaccine schedule updates. First thing to know is the CDC Vaccine Schedules app is your friend. It's for iOS and Android devices. If you already have this downloaded and are using it, make sure you have it set to automatic updates and that you have the addendum updated June 27th as part of the app, as that has the most recent information. It is color coordinated with their schedules. It has hyperlinked vaccine names. One of the nice things is the catch-up schedule. Also, the adult schedule has their grouped by both recommended vaccines, both by age group and medical conditions. So the CDC recommends using the app, as they're not particularly sending out booklets. So either the app or the website, again, either phone or tablet. It has the resources on there. It has the footnotes on there. And again, make sure that you have that addendum updated on your app. So this is a busy slide. This is the recommended adult immunization schedule 2024. You can see it has the different vaccines. It has the tables and notes. It is a very robust appendix and addendum. There were some general schedule changes for 2024. Notably deleted was the bivalent COVID-19 vaccines, which were phased out this summer and should no longer be available. If you have any in your office, they most likely have expired and should be disposed accordingly. So that was removed. Also, the meningococcal group ACWY, polysaccharide diphtheria, known as Menatra, has also been removed as that is no longer available. Added is the Mpox vaccine, also known previously as monkeypox vaccine, the RSV vaccines, the meningococcal pentavalent groups ABCY vaccine. RSV and Mpox were added to the list of vaccines excluded from the Vaccine Injury Compensation Program, and Mpox vaccine is to the list of vaccines covered by the Countermeasures Injury Compensation Program. A new addendum section to summarize these again was added in. This is the addendum. 23-24 COVID vaccines, as I said, are phased out. The new COVID-19, which should be available in your pharmacies. If I know Pfizer is shipped, Moderna, if it's not available, should be coming. Those are what are authorized and approved by the FDA for grade ages 6 months and above. Influenza vaccine talks about the high dose inactivated adjuvanted inactivated for solid organ transplant in immunosuppressed individuals ages 18 through 64. And it reaffirms the recommendation that routine annual influenza for all persons age 6 months and above. And again, all influenza vaccine this year is trivalent, including the high dose. The best influenza vaccine is the one that's available and the one that you receive. Pneumococcal conjugate vaccine, PCV21 is listed now as an option for ages 19 and above for those that are eligible for a PCV. And RSV, we'll go through this a little more detail, has some recommendations on there. So for the RSV updates on the original schedule, you can see what was originally put on the schedule. The new addendum lists some very specific recommendations. One being the RSV vaccination is recommended as a single lifetime dose only. There was a lot of questions when it came out last year whether or not a booster would be required, but it is a single lifetime dose only. And if somebody's already had one, they do not need to receive another. All individuals ages 75 and older are recommended to receive an RSV vaccine if they haven't already. The recommendations for people age 60 to 74 are for increased risk of severe RSV, and there is a note in the original schedule as to what constitutes those severe risk conditions. And also anyone that's living in a nursing home or long-term care facility should receive an RSV vaccine. It is not expected this year to have any supply shortages. There are 2 RSV vaccines currently for adults. Both of them are considered what are pre-F vaccines. Abrysvo is manufactured by Pfizer. It does not contain an adjuvant, and it is bivalent, and it is the only RSV vaccine approved for pregnant people. So if your clinics vaccinates pregnant people, only Abrysvo for RSV, only 32 to 36 weeks during the months of high risk, which Illinois falls into the common region of September through January. Both of them are approved for patients 60 and older. The Arexvy is manufactured by GSK. It does contain an adjuvant, the same adjuvant that is in Shingrix. And again, it is not approved for pregnant people. I think that's the biggest difference between these RSV, and it is what has confused people. So again, the new guidance as of June 27th was everyone ages 75 and older receive a single dose, if not already received. The best time to get vaccinated would be late summer and early fall before the RSV season. It can be co-administered with COVID, influenza, or other vaccines. There is a note section that for severe chronic conditions where they recommended ages 60 to 74. And I will just say on a side note, I have what's probably mild to moderate asthma, and I got mine last year, and definitely recommend it for anyone that has an asthma diagnosis. CDC will continue to update this as they update their risk-based recommendations. This is a poster for the CDC for vaccine to pregnant people. This is a good handout for in your office because it makes it very clear that only the Abrysvo is for pregnant people. There were certainly some vaccine errors reported last year. Nice thing is that the maternal RSV vaccine is covered by vaccines for children. Moving on to pneumococcal. Pneumococcal is pretty busy. This is updated again as of June. They're adding the PCV21 for anyone ages 19 and above who currently have a recommendation to receive the vaccine. This is for adults age 65 and older, how to complete the pneumococcal vaccine schedule, age 19 to 64, if they have specified immunocompromising conditions. This is busy. You need to check this every patient every time. There is a mobile app. This is a wonderful pneumococcal vaccine mobile app, again, available for iOS and Android. Definitely recommend downloading this. It's simple. You enter the age, you enter if they have any specific underlying medical conditions, it takes you through a checkbox. If you know their pneumococcal vaccination history, you're going to put that in, and it gives you patient-specific guidance for that. Very easy to use. Definitely recommend it. As again, the pneumococcal gets rather complicated based on what they've had previously and such like that. Moving on to the HPV updates. This is just more clarification. HPV vaccination, you can see for adults age 27 to 45, basically using a shared clinical decision making model for this age for recommendations for people that have not previously been vaccinated. Also some clarification on the routine vaccination schedule that if for people that have completed the HPV vaccination, they do not recommend any additional vaccines, with the exception of if you have HIV or another immunocompromising condition, you should have completed a 3-dose series, even if you completed the 2-dose series as a young adolescent. Basically, if you're starting the series age 15 years or older, it is a 3-dose series. If you started the first dose before age 14, unless you have any immunocompromised conditions, it's just the 2-dose series as long as you've met the minimal interval. If you inadvertently vaccinate a pregnant person, they do not have to be reported as an adverse event. There is not any negative safety data, but it is not approved for pregnancy. Pregnancy testing is not needed. And again, no intervention if it is inadvertently vaccinated while pregnant. Hepatitis B, new recommendations on hepatitis B are basically that any adult under 60 that has not previously received hepatitis B vaccine series should complete that. There's shared clinical decision-making for ages 60 and older for risk factors for hepatitis B infection, and specifically the shared clinical decision-making for the diabetic patients. So here's the routine vaccination. Hepatitis B has a couple of formulations. They do dose differently, so it's very important that whatever manufacturer you start with, that you complete the series with the same vaccine. If you're unable to do that, then you want to restart the primary series with a vaccine that you're going to be able to complete with. So that's the one recommendation on that. So this is just a slide that recommends some standing orders. Again, if you've done the HepaSlav B, that's a 2-dose series. If you do the others, Energix, Recombavax, or Prehevbrio, those are a 3-dose series. And as long as you meet the minimal interval and you have the same vaccine, you do not restart the vaccine series. Again, if the previous brand is unknown, then you do complete it with a 3-dose vaccine. So again, use your reference if you're unsure about this. Meningococcal has also had updates this year. We no longer have the quadrivalent Menatra. It's no longer distributed in the United States. We now have the pentavalent ABCYW vaccine. So that's been added in for. There's also some new information for people that are not receiving the pentavalent and have not had meningococcal B. If they are at risk and are recommended for meningococcal B, there's a table that helps delineate who to vaccinate, which are basically your high risk, immunocompromised, or if they're living like in a close living situation as an older adolescent. The one thing to know is that these vaccines are not interchangeable. So if you start the series with the Bexsero, you complete it with the Bexsero. That you remember is a 3-dose series. So you need to know that. If we land up in an outbreak, then you give whatever is available as a booster. So if they've received a primary series previously and public health is recommending a booster because of an outbreak, which in our community, because of the University of Illinois, we do see, then any vaccine is acceptable as that booster. But you do want to complete that primary series using the same brand name, meningococcal B vaccine. Pertussis, no major updates here, just some reinforcing of the recommendations. Any adults that are around infants or young children, and that is most of us, certainly all of us that are in healthcare. Babies younger than 1 year are at the greatest risk of getting pertussis and having severe complications. Any adult that has never had actual Tdap should receive at least 1 dose. Boosters, if they're considered adults that are around children, and that would be 10 years for the Tdap, 5 years if it's the tetanus recommendation for a dirty wound or burn. Current recommendations are still for every pregnant woman, every pregnancy to receive Tdap. COVID-19 updates. Again, the bivalent is now removed since that's no longer available. So going on to the newer recommendations, as of June, it is a monovalent, ages 6 months and older, recommending that all adults that have completed the primary series get a single booster this fall. If they have not completed a primary series, they should still do so. And again, those vaccines should be available in the pharmacy, and they can be co-administered. There is a note here about 2324 vaccines that may have expired, but always keep an eye on those expiration dates on the vaccines. Make sure you're rotating your vaccines in your refrigerator. Influenza vaccines, as already mentioned, they're all trivalent, reaffirming the recommendation for routine influenza vaccination for all individuals 6 months and above. High dose for not only those age 65 and above, but also for solid organ transplant recipients. But again, the vaccine that is available is what is the highest recommendation. Our influenza vaccine rates in Illinois are historically fairly low, so we do want to try to encourage that. And again, they can be co-administered with COVID-19 and RSV vaccines. This slide is busy. This slide shows the what is incorrectly perceived as contraindications or precautions to vaccinations. There's a section for all vaccines, such as mild acute illness is not a contraindication. Current antimicrobial therapy is not a contraindication. Then it's also very specific vaccines, what is not a contraindication. For instance, on the live vaccines such as varicella, family members of someone who is immunodeficient may be given these vaccines, and that's often one that has been incorrectly interpreted. Again, very busy slide. Go through this. Make sure that you're reviewing this. If a patient comes and says, I can't have any vaccines, or I can't have a specific vaccine, double check that it's a true contraindication or if it's just a perceived indication. iCare is the Illinois Comprehensive Automated Immunization Registry Exchange. Most of our states have registry exchanges. We are fortunate in Illinois to have a very robust iCare system. It's designed for providers to help record, track, and report patients' immunizations, whether you give immunizations in the office or whether you just make the recommendations. iCare really is your friend. If you're fortunate enough to have a bidirectional interface where goes both ways, so you can record and have them uploaded, that is very helpful. iCare is mandatory for those enrolled in VFC vaccines. Also, if you administer COVID-19 vaccines, they must send that to iCare. But the recommendation would be that anyone that is family medicine practice has access to iCare. It's definitely helpful not only for school records, employment records, pulling off vaccines, finding missed vaccines. Definitely something highly recommended. There's a note on here, if you're doing VFC vaccines or if you've done bridge access program for COVID-19, that has phased out. If you are not enrolled in iCare, it is administered by IDPH. You do have to register for IDPH web portal. This slide will tell you, give you the hyperlink to go ahead and do that. Our iCare support people are generally very helpful at getting practices and individual users enrolled and helpful with information. One of the strengths of iCare is not only can you import the vaccine records and enter the vaccine records into your EMR, not only what you give, but historical. This is very helpful with our transient population, immigrants, refugees, and such like that. So you can pull up a documentation on any vaccine that is entered. It will tell you vaccines that were given that are considered invalid. It'll also give you your future dates of vaccines, so you can plan for when that next HPV is due, or when that, if you're doing a hepatitis vaccine series, when that next one is due. And they're very specific with that. They also easily run reports. So yes, this is something I used all the time in the office. If I wanted to run a report on my patients 60 and above that have not had a Shingrix, then I could do that. I could do it by vaccine. I could do it by age group. I could do it by missed vaccines. I could do it by booster doses. If you're not sure how to run reports, get a hold of your iCare support person. The one thing I will say is that patient needs to be registered to your practice. So if they've moved and they're not in your practice, then they won't show up. Or if they've moved out of your practice, they will be counted as part of your practice. This data can also be used for some of those incentives that that we sometimes are part of. Additional reminders, again, recording all immunizations, even historical. If you do need to report an adverse event, this is information for the vaccine adverse event reporting system, or they can be referred by 800. CDC does list the site for vaccine shortages. So again, if you're hearing that from patients, you can check it on the CDC. And another resource that I'm going to recommend in general, which is immunize.org, which is part of the CDC, but they send out periodic email newsletters that are very handy to just for the bullet points of what's new, what's changed. And with that, I am going to turn this over to Dr. McNeese.
All right. Well, thank you so much, Dr. Kohler, for setting the stage. And, my task today is to talk a little bit about vaccine hesitancy and barriers. And, I know the discussion around hesitancy and barriers and mistrust can go on, and it is multifactorial and complex. But as we get started, let me make sure that this is changing for us. Yes. But the World Health Organization organizes some determinants of vaccine hesitancy into about 3 categories. And when we look at those categories, they organize it into contextual influences. So those outside influences in the society we live in, the political landscape, prevailing religious beliefs, historical influences, and experiences. Also, they divide it into individual and group influences. And in these groups, we talk about, what our mom and our dad and our grandma and aunties believe, what we heard through the grapevine, medical literacy, trust, and personal experiences with our providers. And then when we talk about the third that they divide in group is vaccine or vaccination specific issues. So education, mode of administration, what's deemed important, the same knowledge of our providers, which I point out that they kind of separate, trust and whether we have knowledge in 2 separate groups. So drivers for the barriers to vaccination, despite tremendous benefits of vaccines, most adults in the U.S. are missing 1 or more routinely recommended vaccines. So that's just not our COVID. We've already talked about them: influenza, pneumococcal, shingles, tetanus. And then there are racial and ethnic disparities in adult vaccination coverage, and they're prevalent. In 2019, about 29% of non-Hispanic white U.S. adults age 50 and older had received a shingles vaccine. Only 18% Black and only 15% Hispanic. Well, I think even the 29% is something that is concerning. In a systemic review, which this slide shows, the factors related to increased vaccination uptake in adults age 50 or above most readily include, or the most prevalent factors were economic status, age. So the older we get, the more likely we are to vaccinate. Education, comorbidities. If we have more comorbidities, more likely. Healthcare consumption. So are we established with a healthcare provider or medical home? Self-efficacy. Do we feel ownership of our health? And a recommendation of our provider is very important to increase in vaccine uptake. And it's just another slide to look at some of those components just in more context as they were looked at by the researchers. So we talk about barriers to vaccine uptake, vaccine hesitancy, and racial ethnic disparities were identified as leading factors contributing to slow vaccine uptake in COVID-19 vaccination rates. We do know that there's historical mistrust in our medical landscape and misinformation that is passed. And those were the most frequently reported barriers. The most frequently reported misconception is that was really surrounding infertility and stillbirths or reproductive health issues, which maybe for the population that we're talking about, maybe our younger adults, but our older adults wouldn't really, that wouldn't really move them as much, I would assume. And as time passed during the pandemic and the media cover grew more sporadic, less alarming, then people start to lose interest in the vaccines. They get less information, so they don't know about the benefits. Then vaccines availability is decreased. Community members, studies show that community members who were open to vaccines were often already fully vaccinated, and those who opposed immunization became less interested and, just didn't feel like there was a need by this point. There are also structural barriers, so limited transportation, difficulty understanding English, lack of sick leave or paid time off to come to the clinic, limited vaccine clinic hours, to accommodate workers with non-traditional schedule, and lack of childcare. We hear it over and over again, but social determinants of health also play a big role. Challenges to meeting families' basic needs. So our families, if their basic needs aren't met, this is lower down the line of priorities. Other major challenges to adult vaccination include systemic incorporation of vaccinations into the routine care of adults. Again, we talked about access, not having a primary care provider, out-of-pocket costs. Also, adults receive healthcare services from a variety of providers. So our systems are not talking to each other, which makes it difficult to see or who is responsible for getting the vaccines to our patients. Is it their primary care? Some of them don't really have a primary care and they see a lot of specialists. So who would be in charge of making sure that they are getting the word? Ways to address barriers and increase vaccine uptake. So again, we go back to one of the most effective ways is that as providers, we are recommending it and we are making it a priority. As physician and along with our teams, we play a critical role in promoting immunizations to protect patients. So we need to aid medical homes in increasing uptake. I want to get the organization right, but there is a toolkit from the American, I think it's physicians. I'll get that for you shortly. But other ways we need to ensure that vaccination needs and assessments are routinely incorporated. We need to make sure that, again, that there's bidirectional sharing of immunization and utilizing the client-patient reminder. I don't know about you all, but all those reminders that I get eventually make me go in because I know doctors are the worst patients. So, I think that, it's shown that the more you send reminders, patients are more apt to come in. And so when we talk about resources for our patients, a couple of resources can be readily, and for providers, a couple of resources can be readily accessed. So we have vaccines.gov. All you need to do is enter in your zip code and you're able to pull up where vaccines and the locations that people are able to get vaccines. We talk about Section 317 of the Public Health Services Act. It provides funding for vaccinations and immunization to underinsured and uninsured. The Everyone Project, I don't know if anyone has used that, but AAFP, the Everyone Project, I've used it frequently. But again, you just need to enter your zip code into this site, and you're able to find various services. This is made to address the needs of the social determinants. So financial assistance, food pantries, medical care, and other resources. And then the new resource or website. So this vaccineinformation.org, it provides up-to-date, straightforward information on vaccines for patients. Also, video testimonials from patients, which is good because it gives patients an opportunity to hear the stories of other patients and not just from their providers. So I won't belabor this slide much because I think that this is a good slide to be able to review. But as we are dispelling some of the misconceptions and myths about vaccinations, we need to try to have a bit of a unified voice. And, I won't ever assume that uniformity in thought is always the key amongst providers, but I think that we need to advocate for vaccination and the evidence-based data around vaccination be uniform. And so here are just a list of some of the misconceptions and the facts that you can deliver to your patients. So let's talk a little bit about strategies to address vaccine concerns with our patients. So as health organization and health facility, it is recommended, one, that we measure how well your practice and healthcare system is doing vaccinating patients. Most practices are very surprised to learn that they're not doing very well. Subsequently, we should also assess how well providers are doing in vaccinating their patient and give them individual feedback. We should gather a multidisciplinary team to discuss ways to improve implementation of standards, create SOPs for vaccination to be administered. And if I know most people know what SOPs, but if you don't, I'm one that acronyms. I was in the military. I hate acronyms because they can mean so many things. So SOP is standing order protocols. To implement and evaluate systems that remind patients when vaccinations are due. We need to provide access for patients. So expanding hours, opening up and express lanes just for vaccination. And I also already talked about providing feedback to our providers. So this is just some language and some things that you can think about when we are talking with our patient. It's important to remember that our patients are unique and they have individual thoughts and they're not the same from patient to patient. So one, you need to know your audience and tailor the messaging to them. Highlight the benefits of vaccines recommended. Discuss the people who develop and manage safety of vaccines, not organizations. So, don't talk about like CDC or Department of Health. Talk about the scientists and medical researchers. Seems to be better language to get patients more engaged. And then meet them where they are, in conversation and avoid judgment. Some other talking points to consider, vaccines have greatly reduced diseases that once routinely harmed or killed babies, children, adults, people all over the world, including the United States, still become seriously ill or even die from diseases that vaccinations can prevent. The protection some vaccinations provide can fade over time, and you can remind patients that they might need additional vaccines and boosters and preparing them early for that. By getting vaccinations, they are protecting their children and grandchildren and community. And I know that a lot of times with my patient, I work with a lot of pregnant moms and their relatives and support people. If you get them to realize that, they're more apt to get the vaccination or point that out. Vaccination provides protection not only against the disease itself, but also against the dangers and complications or consequences that they bring. Before we should carefully review the data before recommending any vaccine so that we can be able to answer questions. And then not be afraid to point out that yes, vaccinations have side effects. Most commonly, they can be some fever and some muscle aches and redness and swelling, but reassure that those generally go away in a few days, and this is our immune system working at its best. Serious or long-lasting side effects are extremely rare, and vaccine safety is continually monitored. And then lastly, there are some populations where vaccines are just going to be required. And also, I was a Navy physician, and so active duty, knowing that, a lot of populations you just can't really ask questions. They're going to get it anyway. But also still, recognizing that there are still uncertainties and they deserve education too. So school, students, military, residents of rehabilitation care centers. So when we talk about motivational interviewing, we want to be sure that we're compassionate, we're empathetic, and genuinely curious about what our patients' concerns are. You need to be sensitive to the culture, the family dynamics, the circumstances surrounding the patient. Please don't argue and debate. They do not work. Introduce vaccine as part of the visit and ask to discuss any concerns. And so if you it show that if you just say, okay, today, this is your vaccination that you're due for, or uh, today we'll be administering your Tdap, and then ask them, do you have any questions regarding that? And so kind of make it just a part of the visit. If they do not want it, please respect that. If they're open to discussion or if they're contemplating, um, definitely go over safety risk and impertinent information surrounding that vaccine. And then ask them on a scale after that, on a scale of 1 to 10, how likely are you to get this vaccination? The goal is to help the patient become more open. And so, hopefully, even when they say no, or if they're contemplating, you have planted that seed. And then be able to respond to their questions. And a response is also, I'm not sure about that, but let me direct you to where we can get that question answered. For time's sake, I know that this is shared with you all, but this is a video that you may want to share with um, your providers that you work with, or how to talk to patients that are hesitant. It's only about 1 minute and 30 seconds, but it just gives you a couple of tips. And this is just another schematic or framework for effective communications that are recommended by the American College of Physicians. So again, like I said before, announce that the vaccination is recommended, and this is what we're getting today. You want to inquire if the patient expresses any hesitation, inquire to understand the root of concerns. Then you want to mirror their conversation. So you want to mirror back what you heard, and this lets patient know that you hear their concerns, and that in turn is part of building that security and trust and relationship with their provider. And so with the pandemic, we learned much from the pandemic, including many areas of weakness and opportunities for improvement. Addressing vaccine hesitancy was one of those areas. So approaches and concepts developed during that time can apply with any vaccine. And we have some additional resources here. We have worked hard to incorporate and include some of the resources on this slide, but other resources in the IAFP pages, and we hope that you all peruse. And we welcome questions if you have any. I haven't been reading the chats.
Yes, thank you so much, Dr. McNeese and Dr. Kohler. There are some questions in the chat, and Dr. Kohler, I know you've been answering some of them, so I didn't know if there are some that you want to read out loud and answer for the group.
I can reiterate those. Let me pull them up here. So somebody did ask for some clarification on the MNATRA. The question was whether seen on the CDC app that it was still recommending that. And I actually am trying to pull that up. And if you don't have the current update, it does say it is listed as the ACWY on that lovely 7 to 18-year-old schedule. So just be aware that apparently they did not update that particular colored slide because it is only the pentavalent that is now available. So that was actually a good catch there. And just to clarify on the RSV vaccines, yes, there is a third one that is approved as an adult. It's just not the same formulation and it is not the one that's being confused for the pregnant people. So the CDC really just pushed on that clarification was the update. Anything else? And yeah, Meg just posted the whole link for the pregnancy and appreciate that. The CDC website is very robust for vaccine information for questions. And I'm going to put in the immunize.org because that is one of my favorites for updates also.
Great, thank you so much. If there's any other questions, you can enter it in the chat now and we'll read it. We have a couple more minutes left. I'm actually going to stop sharing my screen so I can grab that link for the post-test. I do see.
I'll answer the question on the pneumococcal vaccine. Let me see if I can pull that. Whoops, there we go. Pull that chat. I lost the chat box. Hang on a second.
And I also see a question from Carol Graham about how often do patients 65 who are in contact with need re-immunization for pertussis. So they're going to get that Tdap, which is every 10 years still for that vaccination. And so as long as it's up to date, they should be okay.
So the comment on the pneumococcal vaccine in patients with conditions, they are saying that you can use the PCV 21 for that. And again, that pneumococcal app is wonderful for checking to see, especially if they've gone partially vaccinated previously, or if they've had 13 or 15 or whatever. But it looks like forthcoming, the PCV 21 will be the recommended pneumococcal vaccine that should cover all your immunocompromised patients also. And
I don't think I see any other questions.
What, there was one more about the COVID vaccine and Part D. I know it's available in the pharmacies. I don't have that question about whether it is also covered in office. I would suspect, like most adult vaccines, it's going to be a Part D vaccine, but you could check that on the state website.
And there's a question
And
here.
no, the bridge program is, sorry, I was gonna say, no, the bridge program, the bridge to access program has ended. So that is unfortunate. I'm hoping that perhaps that will be renewed in the future for uninsured adults.
According to Medicare.gov, the COVID vaccine is covered under Part D.
Thank you. Any other questions? If not, I'm going to share my screen just one more time and show the information on post-test and evaluation and to claim credit. I did put the link in the chat there. So webinar participants, you will receive an email from me with that. The email will also have the link to the resource page and then also a copy of the slides. Online YouTube participants, your link to the post-test and evaluation is under that more and under the description. You'll find that link there. If you have any other questions, you can contact me. And then Dr. Kohler also said that she would be available by email to answer any questions. I will include her email to webinar participants in my follow-up.
Myself also, it's fine.
Okay, wonderful. Well, thank you. All right, well, with that, we will end today's presentation. Everybody can get back to work. Thank you for joining us for your lunch. Thank you, Dr. McNeese and Dr. Kohler, for your time and your expertise. And I hope everyone has a wonderful day.
Thank you.
Thank you.